Hello, my name is Francesca Hearing and I'm the Online Events Assistant at Figo. I'm pleased that you could join us for today's Figo Global webinar, Joining the International Childbirth Initiative, an introduction for facilities and national OBGYN and midwifery societies. The ICI is a joint effort by Figo and more than 20 partner organisations to apply a set of principles in a practical manner to close gaps in the provision of respectful maternity care and achieve consistent compliance with best practices in safe and respectful care. The speakers today will review the 12 steps, process for implementation at the facility level, and formal recognition of sites, as well as the role of national societies in implementation. We're bringing you this session as a live webinar. The webinar will also be available for viewing on demand shortly after the session has ended on the Figo website. Today's presentations will be approximately 60 minutes, after which we will move to our panel discussion and Q&A. If you have any questions, please leave these in the Q&A box at the bottom of your screen. If you see a question posted by somebody else which you support, you can also bring this to the chair's attention by upvoting their comment. If you have any general comments or would like to introduce yourself, please do so using the chat box rather than the Q&A function. You can join the live conversation throughout today's session on Twitter at FigoHQ, where we will be live tweeting during the webinar using the hashtag FigoWebinar. For all updates and information on future Figo webinars, please visit our website or follow us on Twitter or Facebook at FigoHQ. Finally, at the end of today's session, you'll be redirected to a feedback form. This will be anonymous and we really value your feedback on how we can improve Figo webinars. We would be very grateful if you could take the time to complete this. I'm pleased to now pass you over to Dr. Faisal El-Kak, Figo Vice President, to welcome you to today's webinar.
Thank you very much, Francesca. I would like to welcome you, friends and colleagues from different parts of the world to our successful ongoing series of the Figo Global webinars that I would love to call the Figonars. We're very happy and glad today to join with you together the International Childbirth Initiative as part of a series of webinars that are intended to support online professional development and continuous medical and learning and health learning in OBGYN and women's healthcare. It also acts as an interactive platform with Figo committees, working groups, federations, member societies, global partners, regional partners to push women's health and OBGYN practice. Also, these Figonars aim to maintain and position Figo as a leader, global voice for women's health and women's rights. And as we promised, the series continues during the month of February, March, April, and until the summer, so we can keep you busy with a lot of learning and capacity building practices. In case you miss, next slide, please. In case you miss any of these webinars, you can always visit our website, the Figo website, to stay updated and book your slots for the upcoming interesting webinars, workshops, and others. Next, you can always visit the journal of Figo, the International Journal of Gynecology and Obstetrics, for plenty of excellent quality resources that will guide your practice under the COVID pandemics and otherwise. Next, don't forget, of course, our upcoming Triennial World Congress, where everybody meets everybody, where you have all tracks of learning, all types of workshops, and all are made to increase capacity and promote learning and education for colleagues in the 132 national societies globally. It gives me a pleasure now to introduce the International Childbirth Initiative webinar, which is organized by my good friend and one of the most dedicated people to Figo, Professor André Lalonde and his team. Professor Lalonde is the Executive Committee co-chair of the International Childbirth Initiative. He has developed extensive knowledge and expertise in women's health, including in risk management, collaborative care models, health programs to meet the unique health needs of Aboriginal population, and capacity building of health delivery systems, not only in Canada, but also in many places in low middle income countries, where all of these things are needed and where we have always to push and promote maternal health. Dr. Lalonde was Executive Vice President of the Society of OBGYN of Canada for 20 years. That's a long time, Andre. And also held appointments as a clinical professor of OBGYN at the University of Ottawa and McGill. Dr. Lalonde is past president of the Safe Motherhood and Newborn Health Committee at Figo, and is now special advisor to the Figo Education and Capacity Building Committee. He was responsible for the development and monitoring of Figo Safe, the Mothers Program in 10 countries between 2007 and 2011. Dr. Lalonde?
Good morning. I'm pleased to present this webinar to talk about an important issue that all OBGYN midwives and health professionals are concerned with in the past few years and now at the forefront of our care. This is the 12 steps to safe and respectful mother-baby family maternity care. Next. Who is ICI? ICI was formed between a Figo Safe Motherhood Newborn Health Committee and an international mother-baby family organization called IMBCO. We decided to join together a medical group and a group representing a woman from across the world. Now, ICI is a small voluntary executive board representing partner organizations, which were the International Pediatric Society, International Confederation of Midwives, and Figo. In 2018, the current Figo president, Dr. Carlos Fouchner, joined in this initiative and made this a presidential initiative for his term and is hoping that it will continue. The Figo working group is composed of many individuals, which I will come to in a few moments. The ICI is to implement facilities and clinics for where birthing is occurring around the world. We have a growing number of supporters, volunteers, organizations, and implementing facilities, and we hope that it will interest many of you today. The ICI Executive Committee, briefly we'll introduce Kathy Hershefer, who served as the Executive Director, is a midwife consultant from Netherlands. She's also past president of the International Confederation of Midwives, and she has worked very closely with Figo many years ago to develop the first initiative on prevention of postpartum hemorrhage. Deborah Pascali Bonero, my co-chair, she is from a lay person's organization. She conducts international training for doulas around the world and is extremely active with women's groups. Maria Fernanda Escobar Vidarte is Chief OBGYN and Clinical Care at the Fundación Valle del Lili in Cali, Colombia. She is also a member of the Safe Mother and Newborn Health Committee of Figo. Douglas McMillan, representing International Pediatric Association, is based in Halifax and professor in Halifax. Sue Ellen Miller, which is probably known from many OBGYNs and midwives, she's a PhD, and she is the initiator, development, and implementation of the anti-shock garment, which is saving women's lives throughout the world. Claudia Anson is an associate professor at Karolinska Institute and London School of Hygiene and Tropical Medicine, and is working from Sweden. And we have then William Keenan, which is a professor of pediatrics and from St. Louis, USA, and he is also a representative from IPA. Not included in this picture is a colleague from Burkina Faso, Blanzine Tieba, former president of SAGO, the Société Africaine of Gynecology and Obstetrics. And not the least, but most important, is our coordinator, Michelle Scayer-Tedier, who is helping us manage this important project. Next.
Yeah, I'll take it over, Andre. Thank you.
Yes, thank you, Kathy.
Thank you very much. So good day, everybody from the Netherlands. Oh, my video. Yeah, here we go. Okay, now I'm here. Thank you. So I'd like to start off just by giving a little bit of a background on what is Ici, and it's a big thing, ICI.
Kathy, can I introduce
Sure.
you?
Oh, yes, please. Sorry. Yes.
Because I
thank you.
thought that I
Yeah.
will do that.
Okay.
So again, besides Andre, I will gives me the pleasure to introduce one of the active members of the initiative, Dr. Kathy Hershefer. She is the executive director of the International Childbirth Initiative. She's a midwife, so an excellent colleague to the OBGYN, of course, with a team, and a researcher with more than 20 years of experience in community midwifery practice in the Netherlands, later combining midwifery practice with a position as a midwife researcher working in national and international coalitions. Between 2003 and 2008, she was the Secretary General of the International Confederation of Midwives. Between 2008 and 2012, she was employed by the Royal Tropical Institute in the Netherlands as Senior Advisor Reproductive Health and Rights, working primarily in post-conflict situations and fragile states. As a freelance consultant advisor, she has worked for UN agencies, national and international NGOs, and research institutes focusing on quality of care. We're very happy in Figo to have you on board for today's webinar.
Thank you very much. And I'm very happy to be here and to present a duo presentation with my good friend and colleague, Andre. So I'll start off with a sort of a background, what ICI is actually. And to put it in theoretical terms, I would call ICI a framework of learning, a framework and learning network that inspires and facilitates locally owned and locally driven implementation and quality monitoring and evaluation at the facility level. And as we go through the slides today, it'll be more clear what that all means. But we do it by uniting stakeholders, and the stakeholders are varied: healthcare providers, policymakers, decision makers, anyone who believes and is committed to improving quality in maternity services. By promoting clinics, units, birthing centers, or any facility to take part in the collaborative, using the reflective quality, locally driven approach that we've developed. We're grounded in the ICI Foundational Principles that we will talk a little bit about later. And we provide our 12 steps as a framework for safe and respectful maternity care, as a framework for change, with the equitable, our building blocks being equitable, mother-baby, family-centered, and timely, effective, and respectful care. And we facilitate an implementation and learning community of practice for support and real-time monitoring and evaluation for our implementing sites. Next. Yeah. So just how did this initiative originate? And as you can see here, we have two founding organizations, the IMBCO, the International Mother-Baby Childbirth Organization, and Figo, who I don't need to spell out, I think. Seeing the similarities in our previous work, the two organizations joined forces developing one single global initiative that could provide the how-to for the many initiatives in maternity care being carried out. The background document and evidence base for ICI was developed in collaboration with our initial stakeholder partners. You can see them on this slide. That's the White Ribbon Alliance, ICM, the Midwifery Association, and IPA, the International Pediatrics Association. And by collaborating together, we ensured buy-in from the major healthcare professional organizations and women's advocacy groups. And as you can see on the next slide, besides those 5 founding organizations and the initial stakeholder organizations I just mentioned, we have in total combined 23 endorsing partner organizations, and the rest are represented on this slide. They're from all different areas, including providers, educational and research institutions, humanitarian and development organizations, and implementing clinics and centers. Yeah, the next slide. Yeah, thanks. So just a quick background, and I think it's not old news for everybody, but I think what we've seen in the last year is that despite earlier signals about violence and disrespect toward women during the maternity care, especially in West Africa and South America, and we knew that for quite a while. It was Hillenbauer's groundbreaking publication about 10 years ago that brought international attention to the issue of women undergoing disrespect and abuse during the continuum of maternal newborn health and child care. Since then, there's a growing body of evidence, case reports, and many more information documenting this violation of human rights against women and their newborns. Now, if we summarize what we've learned in the last 10 years, and it's not complete, but it includes what we have learned. The major issues is that women's experience of childbearing lasts throughout their lifetime and impacting significantly on their physical and emotional health. Women's perceptions of care influence the uptake of care, resulting in refusal to seek care if they have experienced or perceive the care to be disrespectful. So if they're not treated well, they don't come for care. Disrespect and abuse does not only relate to physical and verbal abuse, which we often allot to that, but it also includes non-consensual care, undergoing interventions they didn't agree to, non-confidential care, breaks in privacy and confidentiality, discrimination, refusal of care, and even retention of patients when fees have not been met. There is a growing body of evidence and case reports collected in maternity care systems from the highest to the lowest resource settings documenting disrespect and abuse. It's not a problem of certain regions, it's a universal problem. Tied to that, the ICI model is a platform to provide the care that women want. And luckily we have more insights into that, and especially from the White Ribbon Alliance, who had a survey a few years ago interviewing 1.2 million women in 114 countries. And the responses really showed that the #1 demand from women around the world is respectful and dignified care. You can read in this slide how women define that respectful care, and it touches on some of the things we just mentioned in the last slide. The ICI steps also incorporate most of the other 20 demands that were synthesized out of this report from women's responses. Next slide, please. So this is a slide, and we want to kind of look at the intersection between what we know about respectful care and quality of care. I started out by saying that the ICI facilitates a locally owned and driven implementation and quality monitoring and evaluation process at the facility level. At its heart is respectful maternity care as a fundamental right for women and their families. This process embodies the paradigm shift that has been spearheaded by the World Health Organization that has taken place, influencing our understanding of what quality service provision really means, and recognizing that there's a broader concept to quality of maternal, newborn, and child health, defined in 2 dimensions, not just the provision of the care, the medical care we give, but also how the care is experienced from the users or the recipients. We also recognize that safe and respectful care is more than the absence of mistreatment or poor communication at the individual level. It also relates to the perceptions of mistreatment due to health system constraints or failures. I think we all know as providers that even with our best intentions, sometimes we're constrained by the systems in which we work and can't do not being able to do our jobs well. And it needs attention at 3 levels of care: at the individual level, at the health facility level, and at the health system level. So it's a large collaborations needed to address these issues. And it needs to be done in a collaborative process with all stakeholders. And the most important is with a collaborative relationship and supportive interdisciplinary work climate between the care providers that cannot be overlooked. And I think that's the last missing piece to the puzzle when we talk about quality of care, which you see very much in the work of the international healthcare professional organizations, working more and more towards collaborating with each other. Next slide, please. So the current concept of quality has brought us many new models centering around recipients of care, and I'm sure they're all familiar to you: patient-centered, women-centered, family-centered. There are many concepts. This inspired ICI to adopt a mother-baby friendly mother-baby family model, recognizing the mother-baby connection. As you can see, we put it together, mother-baby as one word, because it refers to that integral unit that is just, if you work with one, it affects the other. And this is the central part of the unit, but we use the term family to include the father, but also the family, social, and community environment in which a child is brought up. And we all know this saying, it takes a village to raise a child. In the mother-baby family-centered model, the mother-baby family unit is not just a passive recipient of medical care provision. Through inclusion, their values are heard and understood, enabling care providers to meet their needs and expectations. We use the term maternity in this model as standing for the full reproductive continuum of care: pregnancy, labor, and birth, immediate and longer postpartum care. This model embraces the focus of care being the mother-baby family unit, the priority of care, putting the unit at the center of care provision, and the scope of care, the birthing continuum. It is anchored in this current shift from a traditional medical model of care to that integrates the medical model with a value-based model, making health needs and expectations, as well as the desired health outcomes, the driving force behind the decision-making and practice. So that brings me to the ICI Foundational Principles. They were developed by merging the 2 founding initiatives and formulated after a quick exercise comparing the founding work by Figo and IMBCO. And as you can see, we start out with advocating for rights and access to care. And I think that doesn't need any explanation. Ensuring respectful maternity care. I think that's also very clear. Protecting the mother-baby family triad, which we just talked about. The 4th one is promoting wellness, preventing illness and complications, and ensuring timely emergency care. Erasmus, who was a philosopher in my country in the 15th century, said, "Prevention is better than cure." And I think it was later, more than 200 years later, it was paraphrased by Benjamin Franklin as, "An ounce of prevention is worth a pound of cure." More and more, we're realizing again, because we knew it in the past, but again, that the investments in prevention yields a surplus in good health and outcomes. But we always have to realize that we're never able to completely eradicate complications and emergencies. So we always have to balance delicately these 2 aspects in healthcare. And continuing to the last 3 foundational principles. So we synthesized the growing pool of evidence about how women's autonomy and choices can contribute to a positive experience in pregnancy and birth. As was stated and was documented in the guidelines for WHO, a positive experience leads to better health outcomes. And we believe that health providers are key to providing the positive environment, whether it be at the individual level to the recipient or at the systems level, ensuring that the care providers have the enabling and supporting environment they need. And lastly, ICI advocates for an evidence and value and competency-based approach to that is incorporated in the mother-baby family model of care, and which is fed by the midwifery competency model as described in the Lancet series of midwifery a few years ago, and with the optimization of supporting the physiological processes of pregnancy, birth, and parenthood. And then I will turn it over to Andre.
Andre, I think your sound might not be working. Sorry to interrupt you there. I wonder if you could plug your microphone back in, please. Sorry, we seem to be having some technical difficulties with Dr. Lalonde's sound. Dr. Lalonde, please could you, if you could please unplug your microphone, we might try with the computer sound only.
Can you hear me now?
Yes, yes.
Okay.
Thank you.
So sorry about the glitches. I'm now going to present to you in the next 30 minutes the 12 steps, the ideas behind each step, and then the indicators, so that if you want to implement this, then you will use the indicators. This is a bit of a short version because for a hospital who wants to implement this, then we have a longer version where we go through all of the indicators that a hospital can use to show that they are implementing a 12 steps. The first step is provide respectful, inclusive, and culturally sensitive care with informed choice. That is to treat every woman and newborn with respect and dignity. Inform and communicate with the woman and her family decision making. And we know that's a little bit difficult for the medical profession because we know what the woman or what the family needed for care. But really now we have approached this in a different way where we discuss with the woman the different options and we listen to her and try to accept and to support her decisions. And again, we ensure her right to informed consent and refusal, incorporate a rights-based approach, preventing exclusion and maltreatment of marginalized or socioeconomically disadvantaged women, protect HIV-positive women and women who experience perinatal loss. And really, finally, under no circumstances is physical, verbal, or emotional abuse of women, their newborns, and their families ever allowed. Now we move to the indicators of step one. Feedback mechanisms are provided for addressing complaints. Every birthing unit should have a complaint box because a woman or a family may feel kind of daunting to make a complaint, so they can do it by having a complaint box. A grievance process is defined and available to mothers and their families. Most importantly, the Respectful Maternity Care Charter for the Universal Rights of Women and Newborn is displayed in the birthing or in the delivery unit. Women's questionnaire interviews show that there's compliance with this text. And here you see a woman in what White Ribbon Alliance midwife survey showed. The respectful care is very important for them. Next. Step number two, provide free and affordable care with cost transparency. This is a big issue because in my country, in Canada, obstetrical care is completely free. There is no cost to any woman for her care, and there's only one system, and that's the public system. In other countries, it's different, and in some countries, they cannot afford to have a completely free care, although we should all strive to obtain this. So we need to respect every woman's right to access and receive non-discriminatory or free or affordable care. In places where you are charging the woman for their care, you need to inform the families about what charges can be anticipated and how they may plan to pay for these services. You need to include risk pooling so that you don't charge more because a woman had a complication or a cesarean section. It needs to be a fee for obstetrical care, including antenatal care. And more importantly, we forbid under-the-table payments and routinely enforce this rule in our birthing centers. Under no circumstances should a woman or baby be refused care or detained after birth for lack of payment. Next, we go to the indicators. There are no cases in which women, newborn, or infants are refused care or detained after care due to an inability to pay. Survey and interview responses can indicate that the fees they were asked to pay met the advertised rate. And it should be posted. I visited many hospitals where there are some fees, and it's posted at the entrance to the delivery room. And again, it states that They should not do under the table payments. Next, we go to the third step, which is to provide family-centered maternity care, emphasizing that normal birth is safe. Use a value-based model driven by needs and expectation of the woman and her family. This is extremely important because the medical profession has been called to look at their practice because of increased interventions, increases in section rate, which are very, very high in many countries. So this step is to reduce the risk of psychological trauma and enhance women's trust in their caregivers. As Kathy explained, if you don't treat the woman very well, then in many countries, that woman will not seek care, and then it will make her next pregnancy very dangerous. Ensure that this mother-baby family care model is available at all levels of care. So this model, the 12 steps, can be in a local birthing unit, in a small local hospital, in a regional hospital, in a national center, in a level 3 hospital. Women with normal no-list pregnancies can safely give birth outside a medical facility, in clinics, in birth centers, and homes. It took a long time for the medical profession to improve and to support home deliveries. However, we need to ensure that when they're birthing outside an institution, that they have skilled care, skilled personnel, and they have an effective referral organized for transfer. Now we will look at the indicators. The indicators for step number 3 are that women's questionnaire and interviews indicate that this model and associated practices are being practiced in the birthing unit. Posters highlighting the 12 steps should be, I visited a large institution, which is an ICI model hospital in Brazil, and they have this posted in different areas of their hospital. The presence of this model and associated practice and skills are readily observable to assessors. Next, we go to the 4th step, which is to vary all steps. There are no importance in the number of the steps. I wanted to say that at the beginning. Each step is unique, and each step needs to be included to become an ICI hospital or mother-baby family-friendly hospital. We offer continuous support in labor and birth. Inform the mother of the benefits of continuous support during labor and birth. Affirm her right to receive support from companions of her choice. Too many hospitals still around the world do not admit family, either the father or the mother or whoever the woman would like to have at birth. This should be completely changed because this is against human rights and the rights of a woman who's pregnant. Continuous support during labor, we know, improves outcome for women and newborns. They have a more positive birth experience, increased spontaneous vaginal birth, shorter duration of labor, decrease in the number of cesarean sections, less need for analgesic, and less low 5-minute ABGAR scores. This is well documented in literature, whether it's in Canada, the UK, and around the world. Support appears more beneficial when given a person specifically trained for this, such as a doula. Let's look now at the indicators. The indicators for this, and I will comment on the pictures on the right side of labor and birth positions, but the indicators, we can see that there are clear policies stating both verbally and graphically that birth companions are welcome in a facility. How do we do that? We have a picture of a woman and the father of that child or the mother, and we put that in the birthing unit so that this shows the women who are coming into birth that this is acceptable in that unit. Women and families state in interviews and questionnaires that accompaniment was encouraged and supported. And you can see on the right-hand side, and we'll come to that a little bit later, but you can see different positions of labor. We need to teach that in prenatal classes because we know that changing position, having women walk, using a balloon, squatting for delivery, etc., this in itself has a major impact in making a birth easier for the woman. It's interesting that in showing these birth positions, there's one picture I don't have there, but many years ago, I was attending a meeting in Bangladesh, and I went to visit some local birth centers. And in these birth center, labor and delivery, there are no beds. There's a comfortable kind of couch or chair, but there's a rope that is tied to the ceiling, and that women use when they're in the second stage of labor. Interesting, I found in the literature in Canada that about 300 or 400 years ago, with the First Nation people, that they used that. If they had a prolonged or difficult labor, they would tie a rope to a pole or to a tree, and that's how they asked the woman to push, and therefore they saved probably many women's lives. So let's look now at the fifth step. Fifth step talks about pain relief. Very important issue and really central to helping the woman achieve normal childbirth. Offer non-pharmacological comfort and pain relief measures as safe first options. And in the previous slide, we showed you there were women on balloons, women standing, women walking, rubbing the back, massage by the health personnel, but most often by the accompanying person. This is extremely important to teach this to the staff and then to talk about this in prenatal classes so women can expect and use this. Educate women and their companions on how to use these methods, including breathing, touching, holding, massage, relaxation technique, and even laboring in water where it's available. If pharmacological pain relief options are available and requested, explain to the woman and the family the benefits and the risks, so that you need to train staff on all pain reliefs, whether they be physiological or pharmacological. Now let's look at the next slide, the indicators. So here are some of the indicators that you will see. Most of them are repeated in each of the steps, is that you have written protocols about comfort measures and pain relief. So you have, you indicate that you need increased monitoring if you're going to use pharmacological pain relief. Mothers report on availability of pain relief measures via questionnaires or interviews. In interviews or surveys, staff confirm their knowledge of these protocols, and they have practiced this in unit. Is the step number. Next slide, please. Step number 6. Provide evidence-based practice beneficial to the physiology of childbearing. An extremely important step. Right in the middle of our 12 steps, we talk about the practice being evidence-based. Provide and promote specific evidence-based practice proven to be beneficial in supporting the normal physiology of labor, birth, and postpartum and neonatal periods. Some of them can include allowing labor to unfold at its own pace. We all remember, those of my age or younger, that there were fixed times. First stage of labor should be so many hours and minutes. Second stage, so hours and many minutes, and we had to interfere immediately. Well, that's proven to be totally wrong. And so the labor curve sort of went by the wayside now. We evaluate progress of labor in different ways now, and it's not limited to any time. When possible, refrain from admitting laboring women into women that are in irregular labor, women that are not in true labor. So if you admit them, then they will be spending a lot of time in the labor room, and then they get discouraged. They should be either sent home if it's close by, or they should be in another room or facility in the birthing units so they can walk around and see if they're really in established labor. So I think this is important to have available for women these different options when they come laboring. Now we look at the indicators again. The indicators provide mother with privacy during labor and birth. You need to have privacy wall or curtains or separated individual labor and birthing rooms where possible. Now, many countries and low middle income countries will say that this is not possible, but I've been witnessing around the world in rooms where there were 3 or 4 laboring or birthing women, and the women's group, that village or that area, made curtains, made separations, and so you add some privacy to the woman and her accompanying person. I forgot to mention also, some people will not allow the father or accompanying person because they have these labor rooms where 3 or 4 women are laboring. That's not an issue if you have curtains, and really you will see that it's well received by the woman, her family, and the community. We should promote vaginal breech delivery. That could be a lecture in its sense. Probably that could be a good webinar in the future for Figo. I think we should turn the baby into cephalic presentation. Obviously, this should be done in level 2 and level 3 hospitals, but more and more people are coming back to vaginal birth deliveries. Promote delayed cord cutting. This is evidence that is now widespread. Ensure the mother's full access to her ill or premature infant, including kangaroo care, supporting the mother to provide her own milk to her baby when breastfeeding is not possible. Share decision-making with the best evidence should be aspired. The provider should share information, but the woman is ultimately the decision maker. And we need to support the woman, especially if she has difficulty in initiating breastfeeding. And many birthing units have at least a midwife or a nurse that specialize in lactation. And they could be just extra training for regular personnel, because some hospitals cannot afford to have an extra consultant. And again, here for evidence-based practice, you should be referring to international and national guidelines, such as WHO, Figo, and all the major colleges in UK, Canada, US, India, etc. Every country of Figo should have guidelines about evidence-based practice for normal and complicated obstetrics. Now let's look at some of the indicators for step number 6. Posters showing women eating, drinking, walking, and moving about during labor are prominently displayed. Posters illustrating upright and other physiological birth position that includes the woman being supported by a companion. And a while ago in step number 4, I showed you pictures, and I think that's really important. But the pictures should also be culturally sensitive. I mean, you cannot have, if you're in Asia, it should be an Asian woman. If you're in Africa, it should be an African woman that is used to as a poster. And not, I've seen some posters that are completely not culturally adapted. Tools for facilitating these positions we've talked about: birthing chairs, stools, floor mattress, pads, walls, ladder, ropes. All these things should be available. I'm pleased to see this in many countries of the world. I saw a birthing unit that was unbelievable in Peru, and I'm seeing this now all over the world, working with a woman to make everything more pleasant, safe, and according to the woman's wishes. Evidence of staff training in external version and vaginal birth delivery is shown and known to be done. Staff is trained on current WHO and Figo guidelines for managing normal pregnancy and its many complications. Now we move to step number 7. Avoid the routine or frequent use of potentially harmful procedures that have insufficient evidence of benefit outweighing risks. When considering for a specific situation, their use should be supported by best available evidence that the benefits are likely to outweigh the potential harms and are consistent with national and international guidelines and recommendations. And they should also be discussed with the mother to ensure informed consent. In my hospital in Montreal, when I was the chief of obstetrics, we had a monthly meeting with a woman and their families, and we brought a forceps, we brought a suturing needle to show women and their families what could be used in a specific case, or in a high-risk case, or in a case with complications. This was extremely important. The woman told us that that was very important for them to have seen some of the things that we use in labor and delivery, so it wasn't very surprising for them. In the bottom here on the left-hand side, you can see that the Lancet, they had a very important article I think that all health professionals should read. It says, Stemming the Global Cesarean Section Epidemic, and where we are seeing C-section rates of 40, 50, up to even 85%. This is definitely not evidence-based practice. Let's look now at the indicators for step number 7. So here are some of the routine practices that should be avoided. Most of you know them, but we repeat them: enema, sweeping of membranes, artificial rupture of membranes, episiotomy. Some of the more important, frequent or repetitive vaginal exams, withholding food or water, should be people should be able to drink liquids and food during labor, keeping the mother in bed and immobilized, supine autonomy position, numerous caregivers constantly going in and out, fundal pressure in the second stage should not be done, immediate cord clamping unless it's to resuscitate a baby, separation of mother or baby, and we'll come back to that later. I want to just repeat again that withholding food and water. At the McGill University Royal Victoria Hospital, it was the anesthesia department who told us that it was extremely bad to have women without any drink or food for 6 to 12 hours. Because if they did vomit, there was very important complication of getting gastric acid aspirated and then really putting the woman at risk. So really, it came from not only our profession, which sometimes was late to adopt this, but it came from our colleagues in anesthesia. Let's look now at the indicators. Facility, practice, rates, or procedures are within acceptable national and international rate. If you have a birthing unit or hospital, I need to know what is your cesarean section rate, what is your episiotomy rate, what is your rate of induction, and you need to show me that this is comparable to other hospitals in that district or region compared to the national standards, and even comparing yourself to international standards. I believe the OBGYNs, midwives, and all healthcare professionals are proud people, and they like to see that their practice is at the top of the acceptable ranges, and not only nationally, but internationally. So benchmarking with other services is available and easily done. Women's interview and questionnaire, so they're informed and reasons for suggested interventions or procedures, and we ask for their consent. I know this is not done systematically in all the hospitals in the world, but I think by applying the 12 steps in your hospital, you will ensure that this is done. We look now briefly, I know time is going, at the indicators. So I just mentioned that the practice rates or procedures are within acceptable ranges. Different ranges may be expected for referral practice or referring facilities who receive many high-risk patients. Women interviews and questionnaires show that they're informed about the reasons for suggested interventions. And now let's move to step number 8, enhance wellness and prevent illness. And I think that you will need to have a look at this complete slide a little later because it's very full. We could spend 15 minutes on that slide, but really it's to have educational and public health measures to enhance wellness and prevent illness and complications. Provide education about and foster access to good nutrition, clean water, clean and safe environment. Access to disease prevention, such as malaria prevention, syphilis treatment, hepatitis B, toxoplasmosis, HIV, tetanus toxoid, etc. Have clear, non-discriminatory policies for care of HIV-positive women and their newborn, and follow national, regional, or international guidelines. And finally, make water, sanitation, and hygiene a priority, and this is extremely important. Let's look at some of now the indicators for step number 12. Pre- and postnatal education materials and display exist that address the health measures and the prevention of this step. Staff and providers report being kept up to date. Women's questionnaire and review indicate the above components were included in their care. Documentation of family education and preparation for ongoing neonatal care is available. This is extremely important from the side of the collaboration we have with our pediatricians. It's important to have a discharge, how to take care of a newborn, and what are some of the main things that you may worry about and how you should address them. Now let's move to step number 9. Provide appropriate emergency obstetrical neonatal care and transport when needed. Ensure staff are trained in timely recognition of potentially dangerous conditions and complications. So therefore, what we try to do here is that every hospital should have simulation training. You can do that in the hospital. The head nurse, the head doctor get together and they make a program, because we know that there are some periods in a day or in a week where there are less deliveries. Then you can call for a simulation practice of some of the major complications of obstetrics. Have available drugs and devices and equipment to stabilize and treat mothers and newborns. And I often hear some people say, well, I can't do this recommendation of Figo because my government or my health region does not provide these medications. Yes, you need to adopt the use of these medications. And then you use the physicians, the patients, the nurses, the midwives, and most importantly, the public to advocate for this. So I think that is extremely important. And we know now that we have 2 or 3 other important issues. That is that we have now the non-pneumatic anti-shock garment to control severe postpartum hemorrhage and stabilize the woman for a transfer. And even in level 3 or 4 hospitals, because in large hospitals, women sometimes need to wait more than an hour or 2 hours to get access to a operating room when they're bleeding severely. So having the anti-shock garment and applying it immediately, you will buy time, not only for referral, but also to prepare for other procedures. Transport incubators for sick newborn should be available, at least 1 or more in every unit, especially in the local health units. Uterine balloon tamponade for hemorrhage due to uterine atony is extremely important. We need to train staff, and you can't just go to a training and then not use it for 2 or 3 years. So we need 2 or 3 times a year to do simulation training for the non-pneumatic anti-shock garment and for the uterine balloon tamponade. And if the transport is from home to a facility, we plead that you treat well the referring people, because sometimes it's hindsight. We say, well, why don't they transfer earlier? Why didn't they do this or that? No, accept that they did their best. They tried to, bring the patient to you in the best possible form. So accept them. And really in units where there are very few staff, you can use the personnel who comes with the patient to help you in the management. And also then you establish communication with those health professionals who are doing home deliveries so that they feel confident to address you for questions or for training. Let's look now at the indicators. So the indicators is that you need to have emergency drugs, devices, and equipment. You need to have written policies and guidelines for transport and referrals. And in the case of referrals from home to a medical facility, women's questionnaire interviews show that all referrals are welcome at the facility and treated. Again, in my experience, it was in Uganda many years ago, the midwife decided at the health unit that they would have a board with chalk, and they would write the name of referral TBAs that were referring to the clinic. This was extremely important and made them feel welcome. And another experience I had in Guatemala, the OBGYN decided to engage with the traditional birth attendants from the mountainous areas. Why? Because they had a high maternal mortality at the hospital from referral patients who arrived in pretty bad shape. So now they made contact with them, inviting them not only to refer their patients, but to stay in the hospital with their patients. And they made a room for them to stay. And that changed within a year. Maternal mortality from PPH went from about 14 to 15 per year down to about 0 or 1. So extremely important step. Let's move now to step number 10. Have a supportive human resource policy in place for recruitment and retention of all staff. This is extremely important in low and middle income countries because staff are changed quite frequently. And that is a problem because if you do a seminar or a training exercise, you go back to the unit 1 or 2 years later, continuous education, but you need also to have a policy and work with the region that they have a policy of supporting dedicated staff. Now we will go to the indicators. The policy is available on request and address staff safety, security, and exemptions from transfer or rotation policies. Survey or interviews of the staff demonstrate understanding of the policy and can confirm that it addresses the above issues. Birthing units and hospitals are encouraged to work with regional and national policy makers to influence guidelines to implement this step. We now move to step number 11. Provide a continuum of care. Provide a continuum of collaborative maternity and newborn care with all relevant healthcare educators, providers, institution, organizations. Include traditional birth attendants and others attending birth, for example, social workers, psychologists. I know that a colleague in Turkey has a training program where psychologists have a big participation in the program and during labor and birth. Collaborate across disciplinary, educational, cultural, institutional boundaries to provide the mother-baby family with the best possible care within a functioning team. Recognize each specific competencies and respecting each other's knowledge and experience. There is still, I must admit, there are still some tensions between the professions in the birthing world. Some it's between doctors and nurses, doctors, midwives, nurses, etc. We need all to work to eliminate that and to accept each other's competency. And then when we work together as a team, we get fantastic results. Now move to the next step, to the indicators for step number 11. Written policies for collaboration and care and transfer are developed locally or regionally. So we need to have that policy. We need to have in place. And again, I go to my board, and when you see this in a birthing center or in a small rural area, you have the name of the hospital, the phone number of the hospital, and they know who they're going to refer to. And they have a visit from that hospital once a year or wherever they can to come and visit the center and see how they can support them. Surveys and interviews show that they are established and working mechanism for periodic communication and fostering good relationship between facility and community health providers. Let's move to step number 12. I want to keep my time. A very important step, as there all are, but promote breastfeeding and skin-to-skin contact. Components to achieve this step: comply with the International Code of Marketing of Breast Milk Substitute, have a written infant feeding policy that is routinely communicated to staff and parents. Ensure that staff have knowledge and skills to support breastfeeding, which I mentioned a while ago in the evidence-based practice. Discuss the importance of management of breastfeeding with pregnant women and their families. Facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. Many years ago, as chief of my hospital, I was concerned that we were drying the babies. Right after birth, the baby was taken away. They were drying the baby, putting into sheets of clean sheets, except that the baby, when it got to the nursery, was sometimes cold. So the nurses in my hospital, there were only nurses, they discussed with me, and we decided that we would do a simple thing. The blouses used during labor and delivery, they used to tie in the back. We decided to reverse them and tie them in front. And therefore, immediately after birth, they would untie the blouse in front, and it would be skin to skin. The baby's best place, best infant warmer is the skin of the mother. And putting it just between her breasts so she can touch the head of the baby. I mean, she went through a long labor and delivery. This is extremely important for the bonding. And with the father attending at labor, this is fantastic. We also had the father cut the cord, which in some hospitals, it's, you know, they should never do that. But we did this and we never had any complications. We had a lot of trembling fathers, but really it's important for them. And many of them would tell me years later that this was important in bonding with the family. So we want to facilitate immediate and uninterrupted skin-to-skin contact. We need to enable mother and infants to remain together and practice rooming in. Again, this sometimes is difficult in some of the public hospitals, but it can be done. Believe me, it can be done so that you convert the 3 steps where you have the mother and labor delivery, then you have the postpartum ward, then you have the nursery. You combine that in one room where the woman comes in, has her baby, and stays there until she goes home. And that influences breastfeeding. So let's look at the indicators. Here we have all of the indicators, but really you in women's interviews and questionnaires, and we kept mentioning this in the 12 steps, you will see that the Mother-Baby Initiative that we have, the ICI, we have 3 questionnaires that should be filled as often as possible by the person and by the staff. And if you do this a few times a year and you analyze this, then you will see what you need to improve. Here you see that we talk about not having any pharmacological posters advertising infant formula. Culturally appropriate and heavy graphic posters in local languages and dialect, extremely important. And next on the right here, you can see that these are the 10 steps to successful breastfeeding that was adopted by WHO, UNICEF, and then from the International Pediatric Association. That poster should be in all of the labor and delivery rooms. Next. I think I've come to the end of my section. Yes, and I will now turn this over to Kathy to talk about the principles and implementation.
Okay, thanks so much for that, Andre, that comprehensive overview. And there's just, I can imagine people listening now are thinking, how do we do this? You know, there's so much to every step. The steps are so comprehensive with clinical interventions, lists of them, with actions that require changes in behavior, it's system changes. And to be truthfully honest, we don't know it completely, but the ICI principle is based on a learning initiative. So the next step we went into in developing is, how is this going to be implemented? And this slide shows really what our basic principles are, is that you have to work locally with community groups, and I'll go more into that later. We hope that local and national health professional organizations will be involved, because you get the buy-in from the health professionals, and very important, we've talked about that. We also feel that the principles, the steps could be integrated into continuing educational programs and training. So, you know, you can train on the job, you can also do it in advance before people, so they're fit for practice and fit for purpose, actually, after having the initial training and education. And that the steps should be implemented in local and national guidelines. So I'd like to go a little bit further into that, those principles. Can I have the next slide, please? Yeah, thanks. Okay, here we go. I'm just looking. So there is really no one best way to implement the ICI initiative. I'm just for quality improvement, but we did develop some ground rules. If I talk about the ground rules, generally speaking, I would say it's a game changer. It's quality improvement through needed change that has to be determined locally, but it needs vision and commitment. It's not a one-off thing you do for 1 year. Like Andre says, we want to have this to be sustainable and continue. The locally led assessment must be driven by the users and the providers of care, and committed to data collection, monitoring, and evaluation. As Andre mentioned, we have developed some what we call minimum data package. We want to have some continuity in data to not to research this, but to actually have this set up as a monitoring, evaluation, and learning initiative, so that the facilities themselves can keep looking at their own data, which they own themselves. It's not ICI data, and actually use that to drive the next steps in their implementation process. We definitely do not want this to be a top-heavy certification system. We thought a lot about that with outside observations and fees and too many things going on that just doesn't seem to be sustainable anymore in this day and age. But we did recognize that people taking the initiative need to have some sort of recognition-based approval, I guess, just to be recognized for the fact that they're doing it. So we have developed an implementation recognition system, which I'll go into. We know the experiences and lessons learned can be shared in our community, our ICI community of learning. And I think that's the most important thing. As we move forward, we're learning so much. Even the few facilities who are already implementing for us have sent us some of the information, some of the documents they use, some of their posters, some of the things that we've talked about. And it's amazing what's out there. And I think one of our dreams is actually to be able to combine that and have our repository, our toolbox, as we call it, in which we can share to other facilities implementing. So you don't have to reinvent the wheel every time. And again, this process should not be burdensome. It should not be stressful. It should be owned by all involved, integrated into service provision in a way that becomes like a second nature. In Dutch, we would say it becomes your backbone of provision that would withstand changes in personnel and management, keeping it sustainable. Can I have the next slide, please? So this slide really just is a visual of our implementation process. And I don't want to spend too much time of it because I realize our time is limited, but understanding that the implementation of the 12 steps is going to vary because of settings and systems and circumstances. I think it's just an organic process that has to be followed, and every setting will do it in a different way, but we'll learn from each other. In any event, it can be small or large scale, it be top down or bottom up. It all fits into this process. The heart of the ICI implementation and research process is the convening of a local quality committee. That's a requisite. It has to have contain representation from healthcare providers, management, and women in the community or women's organizations in the community. And this oversight committee will drive the entire process. So each step for implementation corresponds to a recognition status. As you can see on this slide, we have 3 phases of implementation. And the sites will be awarded recognition once they've fulfilled the requirements for that corresponding phase. The phases are not based on the absolute number of steps that they've completed, because you've seen yourself, and as Andrea said, there's just so much for every step. You have to choose within the step, what are you going to do to attain that step? And sometimes it will be a longer process or a shorter one. But it's more based on the completion of the obligations for each phase, with the ultimate goals having a fully functioning quality monitoring committee, that local driven community that prioritizes the activities for the steps, initiates the activities for the implementation, and drives and oversees the data collection and evaluation. And as I said, again, it's the data collection, the data belongs to the facilities themselves, and we hope we'll be able to facilitate evaluation if needed or if requested. Throughout the implementation process, the sites are part of that learning community we've talked about, the learning community of practice, which is a web-based platform we've set up, providing support and shared learning. And through this platform, the facilities who are implementing will receive orientation, starters webinars, develop action plans, participate in planned sharing sessions and with other facilitating implementing facilities. And one of the obligations or requirements is a regular communication with the EC exec and progress reports as required to achieve the following recognition status. Can I go to the next slide, please? Thank you. So the last thing I want to talk about today, and I'll have to go through, we're aware of the time, so I'll try to go through it quickly, is that we went through the history of ICI, but what do you need to do to join the initiative, and what role can you play? And the audience is so diverse here. I'd like to summarize in points at different levels where you are. So if you're a national, I need to get my slide. If you're at the facility level, if you're saying, hey, there are people in my facility who are interested in joining, or I'm interested in joining, I would say contact the IC Executive Committee. At the end, you'll see our contact details, and you can we can talk to you about it, we can give you information, and you can receive an application and the facility assessment documents as part of our minimum data package. And we can start the process. You can submit your application. You can join as an ICI starter organization and participate in all the workshops that I mentioned that we offer to get the process going. And you will have access to all the tools we've developed, and we will adapt them as we go along. If you're a national professional society or association, there's still a role to be played. You can contact the ICI Executive Committee again and discuss to become a formal endorsing partner, as some of the many other ones you saw on the earlier slides, in order to advance the ICI initiative in your country. And a very important role right now is that you can help us in translations. I think we're up to, Michelle can tell us in this chat, but at least 20 or some odd translations. We find it really important that all our work is translated into many local and many languages as possible. And we have guidelines for that, and we use 23, thank you, Michelle. We have guidelines for that, and we have volunteers working in many countries to actually put that into translation. Next slide, please. Yeah, okay, thanks. And as we notice now, as we're growing, because we've only been really working for the last year and a half, as our number of contacts and interested parties is growing, we're currently also developing other levels of involvement that would include what you see on this slide. So really, for people who are educators, we need you to come in and help us work with the development of local curriculum courses. We have some universities already on board from Sweden and in Kenya who are actually putting curricula together and trainings information. We have an implementer who's already done that for a humanitarian organization who's also put in some educational models. So we're going to put everyone together to see if we can align that into a good training bundle. We need researchers and evidence partners who will contribute to the ICI toolkit so we can keep updating our evidence, because it's not a static resource. We have to keep moving forward for our background document, but also for the the lists of evidence, they grow, and we have to decide what's important, what comes in and what comes out. And we're realizing we also need ICI champions, so individuals who really believe and are committed to our purpose, who want to promote and advocate for Ici in their respective settings and their networks. Can I have the next one, please? So I'll go through this real quickly because of the time, but what I just wanted to, because we talked about what is the role of international healthcare professional organizations. This is just an exercise that I took a few months ago, and I looked at all the vision, mission, and commitment statements from our major partners of healthcare professionals, so the obstetricians, the midwives, the nurses, and the pediatricians. And when you put that into this, kind of a word doodle cloud thing, you actually see that they're what we expected, that they're all about health, newborns, the people we're working with, but there's a lot about capacity building and strengthening. And if you put this all together, you come out with the common denominators being that most healthcare professional organizations are there to make sure that women's health is advanced, but at the same time to capacity build in member associations. Can I have the next slide, please? Yeah, thank you. Great. So I'm going to skip this now, but it was just an example using Figo as an international health organization, but to show how the mission of Figo, the commitment statements and the goals align with ICI. But I'd like to skip that for now and continue with the next ones, please. Yeah. And I do want to say that there's a role for everyone to play in the ICI initiative. And I want to highlight what Figo's role is at this point and has done. And Andre has introduced you to some of the things. But Figo is absolutely, through these kinds of webinars, informing member societies about us in correspondence, policy statements, webinars, websites, newsletters, the whole thing. They can liaise and collaborate with international partners and international meetings to promote the ICI initiative, which is being done as we speak. They're making the case for safe and respectful maternity care and ICI implementation to policymakers, decision makers, funders, researchers, and educators. They're active participants in the ICI Executive Committee, and we appreciate the support both in help in human capital, but also in financial means to keep us going at this point. So Figo is an example, but the other health professional societies can do the same things. Can I have the next one, please? Yeah. And then to go down the line, we have the role of the Figo societies, but this would be the same for all member associations, whether it's the nurses or midwives or pediatricians or even doulas, whatever, there's all different ones. So really the role you can play as a national organization or a national association or society is the same kind of thing, informing your members about us, developing partnerships in country with policy and decision makers and influences in your national local government, sharing information and just promoting the ICI way of working. Advocate that national policies reflect and promote the components of the 12 steps and identify gaps and advocate for change, and support implementing facilities working with local members who want to promote, finance, and implement ICI. Next slide. In the area of education and training, the national societies can also collaborate with universities, schools, and institutions to integrate ICI principles and 12 steps into curricula, initiate and advocate for the development of courses and continuing education that address safe and respectful maternity care, and stimulate and inspire multidisciplinary and multi-sectoral education and training. And the next one. And again, in the area of knowledge generation and sharing, the societies can be very helpful in collecting stories and lessons learned from evidence and practices that underpin and support the 12 steps, and take steps to disseminate this information and knowledge in publications and conferences and webinars, etc. And when possible, try to initiate research or evaluation related activities on the ICI 12 steps in their respective countries, and champion safe and respectful birth and the ICI initiative into existing and future programs and proposals. Yeah, so I'd like to conclude with our vision for the future, and that is we have more and more facilities and birth centers in all parts of the world who join sometimes I tend calling it a movement, and I don't sounds a little woolly, but it is. It's almost it's a network and a movement for change, leading change for quality improvement in maternity care. It becomes a worldwide learning and sharing community of practice for implementing facilities and centers, that we can get the integration of the 12 steps and curricula into trainings in all regions of the world. And hopefully we might have regional training centers for ICI implementation. There are some ideas about that now. We'd like to eventually have more robust implementation research and be funded for that to better understand how ICI can be implemented and monitoring how it works and how that process can be adapted and made better. And the most important, we hope the Figo member societies and the societies of other healthcare professionals will take the leading and a supporting role in this vision and helping us move forward. Thank you, and I'll leave it at that. Back to Andre. You have to unmute, Andre. Andre? Yeah. Thanks.
So sorry about that. We're now into the question and answer period. And I have read some of the questions. There were over 100 chats. Now we're back to 29 other chats. I want to thank our colleague, Dr. Hakan Koker from Turkey, who answered many of these questions for me because it wouldn't be enough time. Looking at some of the questions, here's some of the questions that we've had. One of them, it says, do you have information material and or posters in French to share with remote health clinics in French-speaking Africa? So I think we are in a process. We don't have all the posters we'd like to have now. And if there are some people online right now who have posters, please send them to us. We'll put them on the website. We'll recognize who made that poster. This is extremely important. We want to have posters for different areas of the world. And I think that we're going to build up our library on our website with these posters in the next few while. Other question, there was another question a little earlier about cord clamping. Two questions, one about cord clamping and the other one was about why put the baby skin to skin. The cord clamping is extremely important. We need to wait a minimum of 1 or 2 minutes. Most midwives and many physicians now wait until the cord is not pulsating. And the importance of putting the baby skin to skin, I mentioned in my talk, is that you will make sure that the temperature of that baby is extremely good. If you put that baby in a bassinet and there's no heating of that bassinet, it will lose temperature and it will get to the nursery and be cold and clammy. So it's really important. The second or the most important thing is that the woman, as I said, is in labor 10, 12 hours, sometimes easy, but sometimes difficult second stage. And to have that baby right next to her, when she can touch the baby. And my patients often told me in feedback, it was so important that they could touch the hair or the head of their baby. Otherwise, in my own experience, I'm a father of 3 children, and I can tell you that when my wife delivered many, many years ago, they took the baby away, put in some bassinet in the corner of the room. And, it was like, and I had to beg the nursery to go in the nursery and to sort of take my baby. So this was old time, and I think we have moved from that now, and we're moving to answer what women want. And if you look at that survey by WRA, please go on the site WRA, and if you go on our website, you will see the results of that survey, and it will open the eyes of many practicing people. Another question was asked that it was about how to get people, I think, in their hospitals to follow current evidence. I think that is a difficult question. And I did mention that in my talk, that there are some strife between the different professions. The only way to do it, there's always some midwives or nurses and some doctors who are sensitive and want to do things differently. Get in touch with them and build up a small group with woman representative, and then you can move forward. In cases where they don't want to understand this, where their C-section is too high, then you may have to call in to the Ministry of Health to have a look at this and to organize a public meeting on normal labor and delivery. I know that we had such a meeting in South America. It was in Brazil, organized by one of our main hospitals who were implementing ICI and IMBCO. And there were over 100 some women or a few men, but there were a lot of government people. And then it was discussed, and now they're starting on a process where they can reduce cesarean section rates. Kathy, do you have some of the questions you want to take up?
Michelle has sent me a few things, so I just wanted to address those.
Yep.
Someone asked about presentations in French, and she asked me to mention that we are planning actually some webinars, this webinar, in I think this one and another one in French and Spanish. So there will be an opportunity to attend a webinar in French, and we also have some slide presentations we have done for French-speaking countries already. So if you contact Michelle, then our website, you can hear more about that. And there have been a few questions about the process for joining, and I went through it very quickly. So, and especially about fees. So I just want to go back to that for a moment, because we said we do have a process for implementation and recognition and joining, and we have decided to have a nominal fee, which is it's all negotiable and discussable. We have a set of depending on the size of the scale, depending on the size of the facility. So that could be sent to you if you write an email to Michelle about that. But I want to say we did that not because we think it's going to support us, because it won't, but it's actually a sort of a buy-in commitment. We want people to be engaged and to stay with us, because this is a process that you can't start lightly. You have to really be committed to work with us further. And as it's a learning process for all of us, we hope that more people will come in. So we don't want to raise the bar by having high fees for that. And again, we want people to be excited, committed, have that vision, share it with us, and join us with that. So I hope that answers your question about the fees. And I'm looking through. Do you have anything else?
Yeah, I have a couple of more. I have a question here. How can we access the ICI toolkit? The ICI toolkit is, many of the information is available on our website. More information is once you register your birthing unit in your hospital and want to implement this. I answered online a while ago during Kathy's presentation that, you don't become a 12-step perfect in the first month or even right now. So once you start, you are recognized as somebody that is implementing the 12 steps. It can take months, it can take years. And then you have available all of the materials on a website, plus you have our support of the executive committee. I have another one that says that he said that access to pharmacological pain relief method is not including an essential. I'm sorry, it is. I said that first you start by non-pharmacological pain relief, soft, massage, etc. But you have this available, and every birthing unit needs to have this available. And this is endorsed also by the International Confederation of Midwives. Another question, which was not kind of interesting, is that why episiotomy should be avoided, which is part of the active management of third stage. I don't think so. This is wrong information. It's never been part of the third stage. And I think that, routine episiotomy now has been proven to be deleterious to a woman, dangerous, causing a lot of pain for unnecessary. So it is to be used in some high-risk cases, some emergency deliveries. And, the accepted kind of rate around the world now is anywhere between 5 and probably 15%, depending on where the risk is, what kind of unit you're doing. Another person said that we should be using enema because women could have stool and it could prevent a baby from descending, or it could cause infections. I think that most of our hospitals in Europe and Canada and US do not do that routinely, or don't even do it at all. You ask the woman, she will have a bowel movement. There is no proof that having a bowel movement during delivery will cause more infections. So I think we're now into that. I'm looking at some of the questions we have here.
Yeah, Andre, there are a lot of questions. There are a lot of questions about the specific interventions. You talked about cord clamping and you talked about the episiotomy. about skin to skin. So I think that's really important. But there's one that's caught my eye about sweeping of membranes, and I think that's a really good one to give as an example in changing evidence. Even our document that we put out in 2018 is being updated as we speak because evidence changes as quickly as possible. So we're going to put on our document with our background information and all the evidence as a digital version soon with an update. Because as we move forward and we see more research coming in, we are changing. And it's interesting, the enema story and I'll go back to the perineal shaving story, how we call it that, because in the 60s and 70s, that were huge issues for midwives and for women, that there were routine interventions done by every birth. And some of the first randomized controlled trials ever done by midwives really addressed these issues in the 60s and 70s, and with evidence showing that you didn't have to do that
I think
regularly.
Faisal wants to.
Huh?
I think
Okay.
Faisal now
Yeah.
needs to
Oh,
come.
I see there. Okay. Yep. Very good. So I just wanted to address that and make sure that it's a continual update. These interventions, they have to be updated regularly as evidence shows us the best practices. Thank you.
Really, I want to thank you on my behalf and on the behalf of Figo for such an illuminating, interesting. And also, I want to thank the audience that's really very engaging and very excited about the presentations for today. I want to thank you both panelists, Katie and Andre. There is really a lot of work here, and Figo is definitely, with its national members, is on your side. I want to ask the audience to stay tuned. As you can see on the slide, there are upcoming Figonars. As I said, we're going to keep you busy. I want you to book the slots for 17th of February, 24th of February, 11th of March for now, to stay tuned to maternal health issues, women's health issues under the COVID-19 pandemic. Thank you very much again. Stay safe. And
I think I have I have a concluding slide or two. I think I have a concluding slide. I think, Faisal, if they want to put it on. Michelle, can you put the concluding slides? So take-home message: disrespectful and unsafe care provision remains a global challenge. Women's voice need to be heard. All stakeholders, we need to work collaboratively. Midwife, doctors, health providers, and their membership societies must continue to make quality of care provision to mother, babies, and families a priority. Next slide. Please join us in this initiative to ensure safe, respectful maternity care. These are the information you need to have: our website, our contact information, info@icichildbirth.org. Next slide. Thank you. We hope that you and your family stay well during this pandemic. Thank you, and have a good day and stay safe in this COVID.
Thank you. Thank you, everybody. Bye-bye. Take care.
Bye.